We do this at UCSF. I'll do this here. It may be new, so I apologize. And I got a lot of these words from different websites, so this might not be perfect. But as a non-Michigander, I'm going to go for it. So this is a land acknowledgement. The university's 3 campuses are located on lands of the Anishinaabe and Wyandotte, and the endowment here was originally funded in significant measure by sale of land granted under Article 16 of the 1817 Treaty of the Foot of the Rapids, also known as the Treaty of Fort Meigs. This grant for the College at Detroit was made by the Anishinaabe tribe, including Ottawa, Ojibwe, and Potawatomi, so that their children could be educated. These lands continue to be homeland of many Indigenous people, and through these words of acknowledgement, we seek to reaffirm and respect their contemporary and ancestral ties to this land and to recognize their contributions to the university. Knowing where we live and work doesn't change the past, but a thorough understanding of the ongoing consequences of this past can empower us in our research, teaching, and outreach to create a future that supports human flourishing and justice for all individuals. A little bit about me. I don't know why I have a picture of myself because I'm standing here. It's very silly. I didn't think of that when I was making the slides. I'm an assistant professor in the Department of Surgery. I am an acute care trauma and critical care surgeon, so I work at Parnassus, sort of the main flagship hospital, and also at San Francisco General, which is our hospital of the city. My pronouns are she, her, hers. I'm DNA, which means I'm a member of the Navajo Nation and white. And I'm funded by the AHRQ, the K-12, as well as the UCSF Pepper Center and the Hellman Foundation. So this is a bridge in Michigan. So I actually had a lot of fun looking at pictures of what Michigan looks like in the spring and the fall. And I love this image and just wanted to start with this while I sort of walk you through part of my journey and my research and what I'm thinking about and adding you to that path. So I had a lovely conversations with lots of you today, and I wished that I could change some of my slides, but it was too late. So you're going to have to bear with me, and I think I'm already learning from all of you, which is really cool. So first, this data is a decade old. These are overdose deaths from prescription opioids in the city of San Francisco. This map is important for 2 reasons. One, people were dying of prescription opioids, not heroin. So long ago when we were talking about, for example, we had this conversation about DARE earlier, talking about kids on drugs. We thought about sort of injecting drugs, right? And so when this paper came out, it was really important to start thinking about these were prescription opioids. So these were opioids that physicians were writing to patients that were going out into the community and people were dying of them. And so just to explain it quickly, the circles were prescription opiate deaths and the triangles were heroin only. So you can see there are far more circles on this map and the circles really span all over the city. Death from overdose, again, in San Francisco has continued to rise. And what is, I think, most important about this slide is what people are dying from. So again, we think about like bad drugs, right? Heroin's a bad drug. Well, you can see here that actually deaths are more and more and more common from fentanyl, an opioid. Now, fentanyl is not something we're not prescribing people to go home on IV fentanyl. But again, we're seeing this shift in what people are using and what is safe and what people are overdosing from. COVID made this all worse. So the darker years are earlier. So 2017 is the darkest year, coming up through 2020, which is the lightest year. Going along the x-axis are months. And so these are numbers of unintentional overdose deaths, again, in the city of San Francisco. The reason we have such great data in San Francisco is because it's a city and a county, and it's one of the only places that's like that. So the county ME can actually count all of these deaths, and we know that they're all in both the city and the county of San Francisco because it's the same. So this A is when San Francisco went into shelter in place, and you can see that these rates were much, much higher after shelter in place. So this is happening in Michigan as well, which I'm sure you are all well aware of. So the most recent data I could find on the Michigan Open website that's complete for the year was 2018. So in 2018, 2,599 Michiganders died from a drug overdose, which was more people than died of car crashes in this state. And another thing to point out is that it's more opioids than anything else. So it's something that we want to think about. Now, we had a conversation today about how prescribing an opioid leading to opioid dependence is actually not related to then opioid overdose. But I think we can all agree that any of these, anything along this continuum, if we can prevent it, especially for people who would otherwise be low risk and we gave them their first opioid, is probably a good thing to avoid. Why is this important to me as a surgeon? So persistent opioid use after surgery is actually more common than you might think. This image is from here. So someone shared it with me to be able to use. This is a lot of different papers. So each row represents a manuscript that has been published. The icons are different surgeries. So it's basically just different body types, right? So colorectal, this is a thyroid, bones, hand, even pediatric surgery. And then these bars represent the percent of patients who were discharged with an opioid and then had persistent or prolonged use, which has a few different definitions in the literature, but most often is thought about at 3 months or 90-day point. So at 90 days, you probably shouldn't have pain from your surgery or the underlying problem for which you had surgery. And so at that point, being on an opioid is seen as this persistent or prolonged use. So these numbers are pretty high, 5 to 19% of people. So we also had this conversation earlier in 2012, or when I was an intern, and I thought of this the other day. I thought, gosh, I have those prescriptions because we used to write them for patients. And we shared a prescription pad, myself and my intern class, which I had. So I went down and found them. Now, I don't know how well you can see this. You can see it. So this is 2015, so probably, well, it doesn't matter. It was a while ago. I'm still embarrassed. But this is oxycodone, 5 milligrams, 40 tabs. Now, as an intern or an R2 and R3, I'm not doing Whipples, right? I'm doing Appies, Colis, some anorectal cases. That's a lot of oxycodone. Okay, this is not my handwriting, so I cannot take credit for all of these. This is Norco, 10 milligrams of hydrocodone, 50 tabs. Next, oxycodone. This is a solution, but either way, 20 milligrams, 60 cc's, plus some Xanax for sleep. I mean, again, not my handwriting, but still, this is, I have more pictures in this, and I had to stop putting them on the slide because I was just horrified. And this was not that long ago. So I also have to give a huge shout out, and before I talk about the work we've been doing at UCSF, I just want to say thank you to the Michigan Opioid Prescribing Engagement Network, which I know many of you are involved in, and is partnered with the Institute for Healthcare Policy and Innovation, doing some really important work that we borrowed at UCSF. So, okay, we have an opioid crisis. People are dying of opioids. People have opioid dependence. There have been some studies, and like we talked about today, people who are on chronic opioids, when you try to taper, they can be at risk of overdose. There's all kinds of bad things that can happen from opioids. Pain is not great either. And in fact, in this country, we've talked about how pain is this extra vital sign, right? And we have these real expectations from our patients that they shouldn't be in pain after surgery. So just saying you don't get any opioids is not really going to work in our country. So what else can we do? There are lots of other things. So people will talk about, I'll take a step back. People will talk about, for example, in labor for childbirth, music, imagery. I'm not sure that the whole American public has quite gotten to, wanting to do that for surgery, or if that would even be enough. So we think about, okay, what are other medications then that we can use? Certainly things like local blocks, epidurals, and then what about something we can give the patient in the moment, right? So this study was looking at the number of people needed to treat for one person to get 50% pain relief. And it actually found that ibuprofen and acetaminophen, you only needed to treat 1.6 patients to get a 50% pain relief. So in this graph, the fewer number of patients who need that combination, the better. And this was actually found to beat out 15 milligrams of oxycodone. So people did better with these and had fewer side effects. So multimodal pain regimens became popular across the country. There are all kinds of reviews, JAMA surgery, in many different subspecialties. So this is something in JAMA ENT, using these for thyroids, parathyroids, and then a lot of studies came out of your group here in Michigan. So all kinds of multimodal pain management, ortho, and then really talking about how patients are really benefiting from this too. Their pain is controlled, they're not going home on opioids, and so this is a win-win. So at UCSF, like I said, we borrowed a lot of things from here and created a quality improvement project to reduce opioid use. So you can see there's a lot of domains that you could focus on. One is expectation setting, which I think is really important, and that starts really in the preoperative area. So as a resident and as a clinical fellow, that's not a place where we had real reach. But we did have reach in patient education, increasing these non-opioids, decreasing opioids, especially at discharge. So this is how we targeted these areas. So we made clear discharge recommendations. Now you would think, why aren't there already discharge recommendations? But they were different for every surgeon, different for every service. So we made really clear recommendations for both number, dose, and how to tell the patient how to use the medication. We had a clear discharge order set. So we're trying to make this as easy as possible for the residents who are working 80 hours a week, they're tired, they want to be in the operating room, right? So however easy we could make this, we did. So we had a discharge order set they could open, it's a dot phrase, all of this is easy, easy, easy. Provider education, provider feedback, so we talked about this earlier too, carrots, sticks, how do you give feedback to people to make sure they're doing the right thing? We made standardized discharge instructions in many different languages because again, at San Francisco General, we're serving a population that speaks hundreds of different languages. That might be a slight exaggeration, but it's a lot. And so to give someone a discharge instruction in English when they don't necessarily read or understand English doesn't make a lot of sense. And you're really not helping that population. And then we made dot phrases for all of these things, and then we reminded the residents a lot. So our goals were twofold. One was to increase multimodal discharge prescribing, so giving acetaminophen and ibuprofen, of course, where appropriate. It's not appropriate in every patient, at discharge, and then setting real evidence-based opioid prescribing quantities for routine operations. Now, we didn't do this for every patient, so it's not like we rolled this out for the patient undergoing the traumatic XLAP or with 2 femur fractures, etc. We included laparoscopic cholecystectomies, laparoscopic appendectomies, inguinal hernia repairs, thyroid, parathyroid resections, and anorectal procedures. And actually, our endocrine surgery department went opioid-free. So their evidence-based opioid prescribing quantity after a thyroid or parathyroidectomy was 0. So again, we established these non-opioid analgesias as a first-line approach, and we did this through a lot of different interventions. So the biggest thing was education, teaching people what this means. So we did this through surgical grand rounds, we had visiting professors, we had a survivor come talk to the whole department, I think, which was really powerful, talking about the first opioid prescription she got and what happened after that. We then had resident-specific didactic and case-based conferences. We made these pocket cards, which had the actual quantities on it, the recommendations, and then feedback reports. So as a clinical fellow, every month there would be a star of the month, whoever did the best job at prescribing multimodals where appropriate, and they would be recognized sort of among the department. So this is at San Francisco General. This is where I was as a clinical fellow. So the x-axis is time, and the y-axis is % of patients discharged on these medications. So you can see the baseline. Blue is acetaminophen, gray is ibuprofen, and green is opioids. So at baseline, we prescribed 0 Nsaids to patients at discharge after these very common surgeries. And with all of this work, we were able to increase the rate of prescribing for acetaminophen, ibuprofen, and really decreased our opioid prescribing. Now, I don't have OME in here, but we also both standardized and decreased the amount of OME we were sending patients home on. from that 40 tabs of oxycodone after a laparoscopic appendectomy. So something else that was really important, and that has been important for me as I've continued to do research and care for patients, is really looking at healthcare disparities. And so one thing we found is that the standardization really helped reduce disparities in opioid prescribing. There have been studies looking at disparities in opioid prescribing by race, not necessarily in the surgical world, but certainly in emergency departments, for example. So they'll, some of these studies look at white versus black patients, and the white patients in the ED for the for similar reasons get far more opioid than the black patients do. So we looked at this. As I mentioned earlier, at San Francisco General, we have patients who speak many languages, and so we wanted to look at this also by language. So I'll use this nomenclature OLP in the next few slides, but essentially people talk about limited English proficiency or even more other language preferred, or OLP. So this is broadly defined as the inability to speak, read, write, or understand the English language at a level that permits an individual to interact effectively with healthcare providers or understand and participate in one's medical care. So about 15% of our patients at San Francisco General, or in the city as a whole, are OLP. And you can see this is Chinese, both Mandarin and Cantonese, and actually more Cantonese than Mandarin in San Francisco, Spanish, Tagalog, and then many other languages. So this is baseline data. This is before the QI project. We looked at all of our surgical patients at San Francisco General and found that our other language preferred patients were getting fewer opioid prescriptions at discharge, so 41% versus 56%. We also found that they got fewer OMEs at discharge. And so just to, since I realized I didn't define this, an OME is a oral morphine equivalent. So it's just a way to say that oxycodone is like Norco. Well, if you get 10 Norcos and 15 oxycodone, is that the same? How do you compare them? So OME makes it all one unit. So you can see that our OLP patients got far fewer OMEs. So even though they maybe got an opioid prescription at discharge, they got a lot less of that opioid. And this was true at the 60th percentile and actually also at the 80th percentile, still getting far fewer OMEs. So what about once groups were exposed to the QI project? So now we've standardized things. Everybody should be getting the same. So we looked at preferred languages, we standardized OMEs, and then when we did this specific study, not that many patients have been exposed to the QI project, 322 versus all of the rest of our patients. So this is, again, baseline. So you can see mean, I'm not sure why the color didn't come through, but mean OMEs dispensed per patient. So you can see for our English patients, they got far more OMEs. But after the QI project, so looking at QI exposed versus not QI exposed, this difference gets much smaller, and this is the difference here that remains is not statistically significant. While the difference in the non-QI exposed patients, that difference is statistically significant. So in the patients who got QI, who had standardization, their prescribing habits were much closer to each other. So QI projects, because of the standardization, can really help decrease disparities. So OLP surgical patients were prescribed fewer OMEs at discharge at baseline. QI projects can decrease these disparities. And I've given parts of this talk before, and people say, well, isn't that better? I mean, why would you want to change this? The OLP patients, you're protecting them. I'm like, well, fewer opioid medications may be more appropriate overall, but we really need to address the system level inequity and, frankly, do the right thing for all of our patients. So this is something else we've talked about a lot today, which is just challenges of quality improvement as an agent of change. So the first thing is this is incredibly time intensive. So when I told you we did surgical grand rounds and we did didactics and we did case conferences, every year there are new residents, so you repeat it all. And every month at San Francisco General in the trauma service, there were new residents. So every month I had to remind everyone about this project, remind everyone about the dot phrase, send the star of the month, all things I'm happy to do, but I'm one person and I was only a fellow for 2 years, right? So then it really depended on myself as a clinician, and it depended on whether the residents were sleep deprived, whether they cared at the moment, whether they could remember the dot phrase when they were sending the patient home. So it's really, really clinician dependent. And frankly, it requires a culture change, right? So we had to get all of the surgeons to buy in. And a lot of the surgeons, as we were joking about earlier, although it's perhaps not that funny, don't want their patients going home on Nsaids because of these risks of surgical bleeding, which is not a risk. But it really requires people to change the way that they practice and change the culture of the department. So what's another thing we can do? System-wide change. As Dr. Ayanian has said himself, we cannot rely just on the efforts of individuals and doctors. You need a well-functioning healthcare delivery system. I could not agree more. So we thought, how do we get the whole system to do this and take it out of this clinician dependence? And so this is a project trying to, again, enhance the uptake of multimodal pain control at UCSF Health. So our aims with this was really to put it at a system level, take it out of the clinician's hands, and implement and evaluate an admission pain order set to optimize this medication prescribing for inpatients during their hospitalization. So switching a little bit from this discharge, and understand some best practices to nudge physicians to do the right thing. So what was our nudge? So we created a new order set. So every patient, when they get admitted to the hospital, we thought, has this base admission order set. I've assumed that it's the same here. But we made ours with 2 versions. So the first version had all of the pain things available, but when you got to the Nsaid part, and I'll show it to you, there was a hard stop. So you couldn't admit the patient without acknowledging why you weren't giving them an Nsaid or giving them an Nsaid. In the control group, the 2 orders appeared, but you could just skip them. So here's what it looked like, pain order set. So first, does your patient have pain? So we realized, and I'll show you actually, a lot of patients get ordered pain medication even though the physician doesn't expect them to have pain. And in this says no, and then they still get pain medication, which I'll show you, which is fascinating. Okay, then, so order acetaminophen. So the other thing we changed about this order set, which I had nothing to do with, but acetaminophen was already checked. So you could uncheck it if your patient's not supposed to get acetaminophen, if you didn't think there's allergy, all kinds of reasons that you would uncheck this. Totally uncheckable, but it's already checked, just like this is exactly how it appears when the physician orders this to admit the patient, or the clinician does this. So then next you have Nsaids. So this is step 2. So you can read this. There was a lot of argument about what the wording should be. As you can imagine, the pain order set committee was anesthesia, surgeons, clinical nurses, clinical pharmacists, and then some clarity builders who helped build this. So a lot of voices in the room, a lot of arguing. I also realized that these don't even say the same thing between the 2. But these were your options. So in the control group, you could just skip this whole section. In the nudge group, you either had to choose a medication or choose that your patient wasn't going to receive Nsaids. That simple. You didn't even have to say which of these contraindications they had. You just click one box or the other. Okay, then step 3, other multimodals. So you can just click some gabapentin, click some lidocaine patches. It's already here. Opioids, all the opioids come with Narcan. We chose oxycodone and Dilaudid. Okay, so then 2 things. 1, process measure, does it work? So primary process measure for this project, were Nsaids actually checked in the admit order set in the first 24 hours? Outcome measures, does it make a difference? So were multimodals used in the first 24 hours? So good for you for checking them, but does the patient actually get them, right? Does the patient get fewer opioids at discharge? And then of course, NSAIDs do have side effects, so we wanted to make sure as we were rolling this out that we weren't increasing clinical harm. So we followed the rates of new acute kidney injury, of new GI bleed, and of Narcan use in the hospital. We randomized nudge versus non-nudge group, and then we actually separated the randomization for surgical logins versus medicine logins because we assumed those patients would be different. We randomized over 1,000 clinicians, and we had 14,696 unique patients with 19,000 patient encounters. Yes?
And so the randomization was based on like the human, the clinician login, like yes. Put you into either of these environments?
That's right. So once you logged in, you were nudge or control, and you were nudge and control for the rest of your time. And same for me. Yes, and so we can talk about this at the end, but there was a lot of argument about whether to randomize the clinician or the patient. I argued for randomizing the clinician, which makes all the statistical analysis really hard on the back end, but I didn't want the clinician to be contaminated. So if you randomize by the patient, and every time I log in, I'm going to see a different order set depending on where the patient was randomized. So we randomized the clinician, and then we dealt with all the analysis on the back end, which basically just means we had to cluster by clinician at the end. Okay, so here were our outcomes. If you'll remember, we had a process outcome, and then we had outcome. We had a process measure, and then outcomes measures. We have lots more than this. Obviously, we pulled a lot more data. And then instead of showing you, go ahead, were you going to ask a question? Okay. Instead of showing you all the tables and the p-values, I'm just going to tell you, nothing was statistically significant. There was zero difference between our nudge group and our control group. Failed study. But the good news is it's a learning health system, so we could see this and then make change. I'm going to show you some really interesting graphs though. So I'll back up just a second before I show you this and tell you that this admission order set was wholly new. So the pain order set committee was not created so that I could run this little randomized control trial. It was created because people at UCSF, including clinicians, patients, thought that the admission order set didn't really focus on multimodals. It had all the wrong opioids at funky doses or like dual opioid IV choices, and it needed to be remade anyway. So while the pain order set committee had been formed and was talking about this new order set, I was transitioning from SFGH over to Parnassus, and everyone thought, oh, this is a perfect learning health system, implementation science opportunity. So when this new order set rolls out, we can try our new randomization engine, we can figure out how to make physicians do a better job at multimodals. Tassi, you do it. But what this allows us to do is also an interrupted time series analysis, because now we have these separate times. So we have, this is pre-new order set. Then we have this middle time, which I'll talk to you about as part of the challenges, but it was all wrong. So we don't count this little middle part, and I can tell you more about how it was wrong, but the order set, the whole pain part of the order set like just didn't open, which it took us about 2 months to realize. So we have pre, mess up, post. And then in the post, we have red, which is our nudge group, the please, please order an Nsaid, purple, which is the control group, the mild pain group. So these are all the patients for whom you didn't click, my patient will have pain. So there's some group of patients who are admitted with medicine problems that don't have pain. I guess I don't deal with those patients. But, and then another funny thing we discovered is this other group. So there were some divisions who had created their own admission order set and had somehow all of these years been getting around UCSF's admission order set, which actually nobody knew till we did the study. So this is the nudge results, which showed no difference in Nsaid ordering. So what you'll notice is just for like a second, maybe it made a difference between the nudge group and the control group. And then, I don't know, clinicians figured out what we were doing and just quickly went back to baseline. Lots of patients with mild pain get Nsaids. And then we're figuring out slowly who these groups are, but these people clearly have some multimodal ERAS pathway going on. Okay, so there was an increase in ordering of Tylenol, which we can see because we did this interrupted time series analysis. So again, total screw up period. And then here, nudge and control, and they both do better. Remember, the Tylenol was already checked. So you had to actively take away Tylenol from your patient when you were admitting them. And interestingly, although not particularly surprisingly, I suppose, that worked. So these patients get Tylenol. A ton of our mild pain patients still get Tylenol? I don't know. Okay, so then our results showed no difference in opioid prescribing. So again, this is an opioid ordered at discharge. Why is this important? Because as we said, if you can get the patient's pain under better control with multimodals, presumably they will need no opioid at discharge because you would have proved they didn't need it in the hospital. Now, there was no difference in Nsaid ordering, so you wouldn't expect to see a difference here anyway. And you don't. They're exactly the same. However, look at all these patients with mild pain who are getting opioids at discharge. So this is another thing we've been looking at. And this shows you the proportion in this group that gets the order, but it's not actually showing you the volume. And the mild pain patients are actually a high volume. So there's a high volume of patients for whom almost a third are getting opioids at discharge, even though at admission, the clinician said, my patient won't have pain. So this study has really opened like a whole lot of questions, more than we have solved any problems. Okay, so then we thought, well, this is not working. So we decided to pre-check Nsaids, just like we pre-check Tylenol. Can someone uncheck an Nsaid? Yes. Can the pharmacist on the back end see that the patient has an allergy to Nsaid and call the person who ordered it and say, hey, you ordered an Nsaid you shouldn't have? Yes. Did the neurosurgeons opt out of this? Yes. Okay, so, but here we go. We've launched. It's been running for 4 weeks. I don't quite have data. I didn't have enough that I thought was, ready to talk about that was analyzed at all. But so far, it actually seems to be making a difference. Okay, so challenges to embedded research. So there are many, many stakeholders in doing anything at a learning health system level, as you can imagine. I mean, just getting the anesthesiologist to agree with the surgeons, to agree with the pharmacists, to agree with the nurses is a lot of work to come up with this order set at all. Then to get the IRB to allow us to study clinicians without telling them or having them sign a consent was actually a huge challenge. Even though this is part of their normal workflow and we could have changed it anyway without telling them, as we have again. You really have to create and then validate this data, right? So it's not, I realize that secondary data analysis is not easy, but someone's giving you data and you're presuming that it's good and that the variable is what it says it is. So as we were creating this data, the people who were helping me create the tables are not clinicians, right? They have clarity access or they know how to use the backdoor of Epic. And so we had lots of funny conversations about like, well, why isn't an epidural an opioid, even though it has fentanyl in it, right? And why aren't we including XYZ in this pathway? Or why are we using this time? And so what if the patient had surgery and then they get admitted? What about all the fentanyl they get in the operating room? Why isn't that included? And so there were lots of iterations of all of this data. And it was really fascinating, actually, all the ways that you can create data. And one of the iterations had tables where the Narcan use in the hospital was 78%. And I'm like, yikes, why are all of these people getting Narcan? But it was just a coding issue that we fixed. But it was really, really interesting to have to go back through and really check some of these patient charts and have all these conversations. And then you're hugely reliant on clarity access. So when we sheltered in place for COVID, my amazing data person was pulled to make all the COVID dashboards. So I had to sort of start over with someone. And then he got a new job. So then we're starting over with someone. And then they have to read their last person's code, interpret what it meant, and redo it. So we've learned a lot as an institution. So we're automating everything now so that we don't have to remake the wheel. It's not like on someone's laptop at their house, right? The code is all in the cloud now. Anybody can access it. And we've actually started to automate some of these tables, some of these graphs, so that it's not just me asking Andrew, asking Jennifer to re-pull the data, rerun the analysis. And actually, we hope that other people will be able to pull and use it. So it will just pull now into tables with p-values depending on, as long as you don't need it really complicated. Okay, and then near and dear to my heart and where my research is really going is thinking about another population that's really vulnerable in the hospital, and that's older adults. Especially older adults getting emergency surgery, older adults who are in a trauma, have a traumatic incident. And as this project continued to grow, I was rounding with my team, and we had this really, really sweet 98 or 100-old woman who had fallen at home and had, bumps and bruises, really small TBI, but mostly okay. And my intern's reading the medication list, and she's like, ibuprofen, gabapentin. And I had to start, I'm like, how much ibuprofen is she on? How much gabapentin is she on? And my intern's so proud, right? Because I'm the multimodal person, and this patient is on multimodals. And her creatinine was okay. We did not give her an AKI, thank goodness. But it really made me think, we shouldn't be giving all these multimodals to every patient, right? Especially older adults. So there's all these unintended consequences of this amazing new order set, right? And one of them is right here. You can just click gabapentin. Well, 300 milligrams of gabapentin 3 times a day for an 88-year-old is maybe not a good idea. In fact, I'll just say it is definitely not a good idea, okay? So gabapentin use is on the rise. This is a study, this was actually a letter to the editor, buried in JAMA. But, you can just see how it's rising. I don't have to tell you. Time is on the x-axis and use is on the y-axis. And it's rising in surgery too. So these patients in our order set are getting way more gabapentin than baseline. This isn't by older adults, so I need to redo this data looking at just older adults. But we're using it more, and we might be using it inappropriately. And gabapentin can be really dangerous in older adults. It can cause, in any patient, it can cause sedation, confusion. But older adults have different pharmacodynamic properties. And so these effects can be even more. So dizziness, that can lead to falls, fractures, which is maybe why the patient was in the hospital in the first place. Respiratory depression. So there's some studies now looking at gabapentin and opioid use, and that can actually heighten respiratory depression in patients in the hospital. Renal dysfunction. So you almost wonder, is gabapentin worse than a low-dose opioid in older adults? It's now on the AGS Beers criteria list, which is a list published to make physicians aware of dangerous medications for older adults. So we talked about new persistent opioid use being common. Well, what about persistent gabapentin use? So when we're sending these old people home on a gabapentin, which is already probably not good for them, are they staying on it for a long amount of time? And in a prelim study looking at just 5% Medicare data, 1/5 of older adults are still feeling gabapentin 3 months after discharge from surgery. For older adults, this can be really devastating because they're already on other medications too, so polypharmacy can be a big problem. Why is this a problem? Lots of speculation, but an area of future study. Here's the bridge again. I just want to thank all of you so much for having me here today, for listening, and for being so willing to collaborate and talk about all your work. It's been really, really a pleasure. And of course, thank you to all my mentors and people who have helped me in my career along the way, and to my really cute kids. So thank you so much. And I'm happy to take questions or comments, conversation.
Do you think that people have no idea what multimodal means? Because it sounds, at the beginning of your talk, it sounded like multimodal was not opioids. But toward the end, it's like, well, there's all these off-label things we can do, like let's throw gabapentin at people. There's no reason that I'm aware of that gabapentin should be considered a terribly effective pain reliever. It's not what it's intended for. Is there something I don't know about gabapentin that suddenly people are jumping on this bandwagon?
I think a lot of people are using gabapentin as an adjunct, as an opioid-sparing adjunct.
But what's the evidence for that?
Oh, I don't know. That's a great question. I don't know that there's a whole lot. I mean, there are papers, you're going to have to help me out here. There are papers about people getting gabapentin or pregabalin in the preoperative holding area, and that their reported pain after surgery is better. So I think based on some of this evidence, people are then using it into the postoperative period. But there are definitely studies about it reducing pain, especially in orthopedic procedures. And so then that's just getting used for all patients.
I got it in recovery after my total knee replacement, but I don't think it did a hell of a lot of good. There are two other barriers that I've encountered, and that is surgeons telling me, surgeons who are operating on me, telling me I couldn't take nonsteroidals because it would affect my wound healing. What's the evidence for that? Well,
Oh, I shouldn't have unplugged this.
theoretical reason for that.
Yeah.
Or the other one was because of the risk of bleeding, which, as you pointed out, is not a risk.
Totally theoretical. Hang
But
on.
the interesting history on that is that 30 years ago, in the early 1990s, I was on the panel that wrote the first postoperative pain management guideline. And at that time, I learned that nonsteroidals worked and started using them and stopped using opioids for a lot of stuff. Everybody thought I was nuts.
You were far ahead of your time.
So, I mean, I did endocrine surgery without, it's not that I was so good, but the thing that's discouraging was, even though it worked, nobody else really wanted to adopt that. And I was thinking, are we really a learning institution or not? And it sounds like you have a little bit of that barrier as well. It's like UCSF may not be as much of a learning institution as you think it is.
Yeah, absolutely.
Yeah, on that last point, have you all been able to feed these data back to the clinicians and get people's input? Because a lot of the stuff you mentioned is like, well, this doesn't necessarily make some sense, or a lot of it, as a resident, I was a resident, same time you were, I was told at the beginning of residency, opioids around surgery don't lead to persistent use. I lied to a bunch of patients and told them that, because that's what I was told when I was an intern. And then later, once we all started talking about it, then we said, oh, actually this is a bad idea, and there were like systemic changes. But it was really when we're talking to each other of like, yeah, I don't do that anymore. Oh, yeah, I do this instead. Are people getting the feedback and what their baseline prescribing is, or how it's changing, and how has that informed sort of future directions?
Yes. So when we were doing the smaller QI project, we were just more nimble because it was just the Department of Surgery. We could give feedback to residents. You don't want to shame anybody. So we would give the resident their feedback sort of with their average OME in a graph with other nameless columns.
They knew like where they were.
They knew where they stood, yes. Doing it on this bigger institutional level, it is challenging just to get this data in front of you. Like it was great actually, because I was like, well, I'm going to Michigan next week, so I need this. In the gabapentin chart we did last night, because it's hard to get all of that data from the health system, have it be accurate, and then be able to run analyses, it's a great question. We could do this by department, by division. I mean, you can imagine looking at all the medicine patients. If you pulled like all the CHF patients or the patients who are admitted for pneumonia and showed this data, there's so many things that we could do, and frankly, that we should be doing with it. But it's getting it all kind of straight in our own heads first, which I guess is not an excuse to not be telling people. So thank you. And on your note, we actually did a systematic review on, this is just for everyone else in the room, is such a huge surgical dogma that NSAIDs cause bleeding and wound healing. And so we pulled 74 manuscripts that looked at bleeding in surgical patients. And this was either surgical bleeding as defined as a hematoma, or take back to the OR, or a hemoglobin drop that was statistically significant between the two groups. This graph really means nothing. The point is there was no association whatsoever with NSAIDs and surgical bleeding. Just to put that to rest.
I have one narrow question and a broader one. The narrow question is, the Tylenol use that you were tracking, was any of it for managing fevers? Can you distinguish whether people were actually ordering it for pain versus?
That's a great question, no.
Okay. And then the broader question, were you collecting any data from the patients sort of going through about their patient-reported pain control?
Also, sort of. So we weren't doing it as part of the study, but we did pull pain scores as we were going. So I actually can't remember exactly what the policy is, but I think most hospitals have a policy where patient's pain score has to be assessed at some point multiple times during their hospitalization from 0 to 10. And so we pulled average pains, we pulled median pain score in the first 24 hours, the day before discharge, and then day of discharge. In this study, there was no difference at all. And I'm not sure that we have enough data yet for the new rollout to see if there's a difference, but it would be great if there was to prove that, yeah, we're doing a better job. Now, are we asking patients in either a quantitative survey or qualitative way, has their experience changed with getting medications? We haven't done that yet. Oh, sorry, go ahead.
Just a quick question for clarification. I'm a clinical pharmacy specialist in pain management, and we are undertaking a pain management order set. I'm so curious what some of the barriers you have just experienced in your process and kind of undertaking an order set for multiple different areas. The order set that you presented on, was that health system wide or specific to surgery?
Health system wide. Except for PEDS. Okay. So PEDS just rolled out. And that was, I think, actually an even harder undertaking.
And it was an admission, part of the admission order set rather than its own existing?
In the admission order set. Yeah, so it's like a drop down, just like IV fluids, pain, VTE prophylaxis, diet, all of those things in the main admission order set.
Yeah, I know what Jillian's talking about. So you have just one order set for anybody who's going to admit a patient to your hospital?
Well, we thought so, but then you saw those blue people. So I don't know who those, we don't know who those blue people were.
You know? So because all these people are going rogue, you know, on these order sets, and that has been the issue. And then how did you get approval to add this? Because that's been the other massive issue with getting approval, because I don't know how Epic works at your place, but we need, like, there's an order set champion for every surgical service, and they need to give you approval to make these changes. Is that the same thing, or did you have sort of the power to make that change because you were the pain order set committee?
Well, I certainly didn't have the power, but there was a surgeon on the committee who did, who far outranks me, and she just said, these are the changes we're making. And you know, some of the surgical divisions have their own, and this is your question too, they're like have an addendum, but it didn't really matter because in this order set, Tylenol was already checked and you had to check Nsaid or not. So even if you added an addendum, it wasn't going to get you out of the beginning stuff. So ortho for a long time had an addendum because they wanted to use celecoxib, and in the old order set, celecoxib was never an option. So they just made their own addendum pain order set so they could easily click Tylenol, celecoxib, whatever, to get around that. And actually what the pain order set committee is doing is trying to sunset a lot of those addendums for exactly the reason that you're saying. There's like so many different options. Yeah, right. So that makes it really difficult. But this was not, the pain order set was not a idea for a research project. It was from the pain committee said, our pain order set sucks, you guys have to redo this. And so as we redid it, we started this like A/B testing. So yes, it was definitely a problem, and it still is. So we're working on it slowly, but that's not my job.
Thank you for sharing. It's just fascinating, and I think we've come across some of the same barriers, and it's just so interesting to hear what we're doing.
No. I mean, it's a giant health system, right? So you have, that's why one of the challenges is really there's so many stakeholders who have different goals too. Yeah.
So you standardized opioid prescribing as well in your order set. So I think I saw it there that somebody would click a button and it would
Yes.
automate the prescription of an opioid.
Yeah, so we actually, well, that was for inpatient.
Okay.
That was for
Oh, so
inpatient. So just inpatient, how often? And then we actually created an order set for discharge also. But again, that's a little one you had to sort of wrench in and add. And that was just for discharge.
And that included Tylenol and Motrin as well. in that
It did.
set.
And so a challenge, though, for patients who have private insurers, they still have to go to the pharmacy and just buy it. Like, no, you can't just, right. So we got lucky because it's, not lucky, but it's San Francisco General because the health system is through Healthy SF. The outpatient pharmacy is within the hospital. So when people went home after their Appy or their Coli, they were actually handed Tylenol and ibuprofen. Yeah, because then they don't have to go to the CVS and buy it because they might not have money to do that. So they just get it and go home that way, which is great. It's too bad that we can't do that actually at the main hospital.
So I've done a lot of work to standardize opioid prescribing as well as the automation of Tylenol, Motrin. One of the issues we run into a lot is surgeons, and I work specifically in surgeons, their preference with either oxycodone or some formulation that includes Tylenol, acetaminophen, and then we're ordering acetaminophen. In addition to that, did you have those challenges, or how did you land on, was it oxycodone?
It was Oxy. We did Oxy.
And that was probably to avoid contraindication or too much.
Yeah, well, I mean, I think the pharmacists in the room can speak to this more than me, but I think Norco was created so you had the Tylenol in it. So you were getting the patient to take Tylenol, and you didn't have to worry about overdose. But obviously, if you're giving someone Norco and Tylenol, it's really hard to calculate the difference. So that's why we did oxycodone to make it really easy. And I'll tell you, we had Tramadol also in the beginnings of this. And it turns out Tramadol's not that great of an opioid. Like, you just give somebody the opioid. But as surgeons, we were like, oh, people love Tramadol. And all the pharmacists were like, no. So we took it out, but that's why it's going to be on a multidisciplinary team. Because our prescribing was Oxy or Tramadol. But yes, we got our, yeah. Perfect. So we learned. We adapted. But oxycodone was just easy because then you could tell the patient Tylenol, ibuprofen, Oxy if you really need it.
And you didn't have any pushback on that? I've been fighting that battle for 2 years, people insisting they want to prescribe Norco as opposed to oxycodone because it's a less intense opioid, so they say.
Oh, that's interesting. No, partly because the residents do all the discharging, right? And so I think the culture change was a lot less severe because the residents were like, sure, whatever, you're making my life easier, I'll just do it.
Beautiful thing.
Yeah.
An observation and a question. The observation is, we put the opioid prescribing open networking across 69 hospitals across the state. And one of the interesting comments that came up at the meeting we had a week or so ago was that the hospitals where they were not meeting the guidelines were blaming it on the hospitalists who were doing the discharging. Because we've gotten to the surgeons, but the surgeons couldn't get to the hospitalists.
Interesting.
To change the system. So it tells you this, the whole system has to change in a way. And
Yeah.
the question I have is when you look at the fact that you seem to get a difference and then it sort of tapered off and things did change. And I wonder to what extent that relates to the fact that when you're just clicking buttons, you're not thinking.
Yeah.
There's no cognitive input. And we know this from the electronic health record that people, just check off all kinds of stuff on an H&P and then put a diagnosis down, which is totally unrelated. And there's it doesn't connect in their brain that what they're doing is nonsense. And I just wondered, you have to, I think the nudge idea is a really good one. And I really appreciate your being honest about your results. I was wondering, how do you nudge people and also get them to learn as they're being nudged what's going on?
Yeah. I mean, we keep trying. I think these questions about how are we giving this feedback are really good. I think it's like taking a test, right? Until you answer that question and get it wrong and then have to think about it, it's hard to get people to engage. So you can read a textbook all you want, but when someone's like, what is the answer? That's when it really sticks. There's a whole book called Make It Stick about how you get people to learn and retain that information. And so I think feedback is going to be a big part of that, which we haven't even started.
Failure is a big part of it, as you point out.
Yeah, and failure.
Doctors hate to fail.
Yes, yes. Well, and in fact, when we were showing the residents their results, again, anonymously, I mean, they weren't anonymous to themselves, but everyone else was anonymous. We saw change. It's just hard, again, to do that unless you've automated that process, right? Because otherwise it's me fixing the data and then showing each division. And so until we have a better way to do that, then it's just me.
It makes you wonder, the job of the chief resident is to teach the juniors, to teach the interns, and, just listening to the experience of my son who's a junior, who's a mid-level resident in surgery now, how all the teaching that he is doing to the HO1s so that they get things right. So theoretically, the system should be self-sustaining if, in fact, the senior residents believe in what they learned at things.
Right. But that's part of the problem. Like, it's a good thing that Dr. Scott didn't keep telling everybody you weren't dependent on opioids.
I was just relaying them.
And actually, when I was a chief resident, I remember one of my co-chief residents telling the interns that Tramadol was way better, especially for older people. He would make them put all the older people on Tramadol. I remember thinking, really? I don't remember learning that, but then I learned the opposite. So, yeah, you're right. It can be good, but it could be also part of the problem.
Is it in the resident didactic curriculum? Like
Well,
the, protected
yes.
education time?
Quality improvement is now part of the didactic program, so we actually have a whole quality improvement series, and part of that quality improvement is this project, like part of the teaching. But then, yes, making sure people have the dot phrases and the appropriate discharging and everything. It's in the handbook. I don't know how many people read the handbook, but they need to reference it. It's there.
Do you suppose that doing quality improvement is an impediment to research? And I ask that question because I've done research, I've done quality improvement. The interface is often awkward. And I don't know, I just wonder if you had sensed that tension.
Well, awkward and not allowed. But what do you all think? I'm curious. It's a really important tension that.
Well, there's a lot of impediments to research that you overcome by just doing quality improvement.
Yeah.
And,
Like no IRB?
right, well, among other things. But then you can't write papers about it.
Yes, we did all of this through the IRB, for exactly that reason. But yeah, I mean, they almost weren't going to improve this study. And we finally said, look, we can do this whether you approve it or not. It's the order set. We're changing the order set. We're not asking for permission for that. Why do we have to ask permission for whether we check an Nsaid or not, right? I think there's a lot of tension.
Did you create a timeline though that showed, quality improvement thing, so here's our standard, and here's where we're going, and things are not getting better, so we need to make some more changes. What changes do we have to make in order to?
No, but we did put in the clinical harms, and that we would be tracking the clinical harms every 4 weeks to make sure we weren't, for example, increasing the rate of AKI especially, or new GI bleed, but those are so rare anyway. So those 2 things I think helped. I think it's a huge problem. It's a huge problem for learning health systems, because either your health system learns a lot, but then you don't tell anybody else, right? Or you can't roll out these projects because the IRB takes so long.
That gets at the tension, because if it's a learning system, it should be learning on the basis of its quality improvement and its results, and making changes and seeing what the results of those changes are.
Right, totally. I agree. People always say this, I sort of hate the comparison, but that Grubhub is apparently changing things in the way it shows you your options on like a daily or every other day basis. Amazon's doing the same thing too, right? They're all constantly learning how to market to you better, but either way, we could be constantly learning how we're providing patient care better. We just don't have a whole team that does that, right?
Sorry, this is unrelated, but one of the things that I'm looking at now is pre-admission, like oral morphine equivalents compared to like our discharge oral morphine equivalents. In your work, were you able to do, look at subsets that were on like so many OMEs prior to certain interventions?
No, our MedRec system is really not great. And wouldn't it be great if we could get cures data? Or that's what it is in California. I guess I don't know what it's called here. Yeah, if we could get that data and merge it with our hospital data, because then you would know actual, not prescribing, but filling data, both pre and post. But the DOJ is like, absolutely not. I actually tried for 3 years, like letters, phone calls, went up to Sacramento, whatever, and they won't do it. They'll give us de-identified data, but it's so, it's de-identified all the way to like a zip code level, so there's no way to match it. And then probably like you do here, we take care of patients from all over the state. So it's just really hard to track any of that if you don't have like an individual level. It's a great idea though.
Yes, are you exporting any of this to other UC health systems? So, we've been hearing that the University of California is trying to create kind of more of a statewide network of all the UC health system campuses, and with shared data.
Yeah.
Are there collaborators or potential collaborators, other sites?
No, but that's a great idea.
It sounds like we might help export it here though. No, we're not, but that's a great idea. What we are doing is collaborating with SFGH, partly just because we're there. So many of the surgeons go back and forth, that anything really we're doing now that's working at Parnassus, we're doing there too. But that's not quite such a big collaboration, but that's a really good idea too.
Well, as I understand it, they're trying to reconcile the data systems so they're comparable to all the
Yes.
sites, and that
That's
potentially makes this.
That's true. I think not very many people have used that yet, but yes, they're actually during COVID, I think is when they started really trying to ramp that up. It's a huge amount of data, the whole UC system. I've been hearing all day about like, the state of Michigan has this and the state of Michigan. The state of California doesn't have like some database like that. It's so cool that you do. But yeah, having all the UCs come together would be a start.
Or sort of if you could roll out different interventions at different sites.
Right. Because then you would need like a week to see change because there'd be so many patients. Yeah. Thank you all so much for being here, for engaging. It was really lovely.